Hello, everyone, and thank you for joining us to our webinar series. This is the third webinar in Gynae Fellow webinar activity for the year. I'm delighted today to have two eminent speakers and friends. Professor Jan Beekland from Belgium, who is going to take us through the vNOTES, and very much look forward to his talk. And my dear friend, Mr. Tom End from the Royal Marsden in London, who kindly also agreed to take us through the robotic surgery and the advances in robotic surgery in gynecology. I would like to thank you for attending, and also thank our speakers for giving us the time and sharing their expertise with us. Of course, we would like to thank our sponsors, Johnson and Johnson, for their continuous support. Needless to say, the team behind organizing these webinars, of whom you a lot that you don't see, so thank you all. I would kickstart the meeting with my colleague, Mr. Moday Ali, who's going to consultant gynecologist from Cumbria, who's going to co-host the meeting with me and kickstart the meeting by give us a quick introduction. So to you, Dr. Ali.
Excellent. Thank you very much, and it's an honor to be in this platform with great people. I would like to share my presentation with you about hysterectomy. If you can see my slide, let's share screen. So I'll keep it really short and sweet. Starting with hysterectomy, it's a combination of two words, hystero for uterus and ict is to cut. However, it does involve not only removal of the uterus, but sometimes this procedure does involve removing the tubes and ovaries, sometimes cuff off the vagina in cases of cancer. So it can be classified into total, where the cervix is included. The advantage is, there's no need for smears, and it's protective against cervical cancer. The other one is subtotal or supracervical, where the cervix is retained. Usually, people are moving away from this, approach, because 1 in 4, in general, of these cervices need to be removed later, either for bleeding or pain, or sometimes concern with cancer. The radical hysterectomy is where a cuff of vagina is included in variable degree of parametrium. I do invite you to read the nice paper from Chipela 2011, where he has worked on the classification of hysterectomy into A, B, C, D. It's a nice review. So, I mean, not to trouble you with a lot of basic anatomy, but I want to say that we have new optics for anatomy. We have the laparotomy anatomy, but also with the advancement of optics in laparoscopy and the 3D, we have laparoscopic anatomy, so we can know about spaces and nerves. But also a new technique, the vNOTES, we have the laparoscopic view of the pelvis from the vagina. Just simple points about certain aspects of anatomy. We need to consider whether we are conserving the ovaries or not. Now, routinely, we remove the tubes, a part of tendency to protect against cancer. I want to say that bladder reflection is a very important step in the procedure, either way, because there is increased risk of injury with cesarean section. Again, we all worry about the ureter to uterine artery relationship. And also, we need to know about pelvic spaces, especially for oncology, endometriosis. And also, we need to think about the vault closure and support. We started to know more now about pelvic neuroanatomy in more detail. Just a quick review about incidence and trend. Generally, internationally, the incidence of hysterectomy is diminishing. It ranges between countries between 5.4 per thousand to 1.2 per thousand. Is dropping by 1% every decade. But almost 1 in 5 women will need a hysterectomy. In the UK, just an old data, in 2011, around 56,000 ladies needed hysterectomy, and you can tell that then 35,000 were abdominal, 18,000 were vaginal hysterectomies. So just a bit of history about hysterectomy. The first report of hysterectomy in history was 120 BC, where basically a prolapse uterus was chopped. We don't know the outcome of that, but there were various reports of hysterectomies following that, but the mortality was very high. Basically, with prolapse uterus, you cut it and there will be septicemia and infection, hemorrhage and fistulas. However, the first planned vaginal hysterectomy was Langenbeck, which is, we know we use the instrument Langenbeck in the theater, and he's the first one who performed planned vaginal hysterectomy. Nobody believed him until the lady died 27 years later, and she had a postmortem. So the first planned abdominal hysterectomy was in 1843. However, I think patient died then. The patient in 1853 did not die, and she was the first successful abdominal hysterectomy. In 1905, Wertheim, Viennese surgeon, reported 270 radical hysterectomies for cervical cancer. And Pfannstiel, famous for the incision, in 1920 described the incision, which is instead of midline, it is like a smiley incision, more cosmetic. It was popular for that. In 1929, Richardson performed the first total hysterectomy where the cervix is formally included in the specimen. So further development in 1930, 1950 included major advances in anesthesia, antibiotics, antiseptic, and also the introduction of radiotherapy that greatly modified the surgical practice and influenced how we do the hysterectomy. After the Second World War, Raoul Palmer developed, basically he's the father of gynecological laparoscopy, and he studied the intra-abdominal pressures. But the first, basically we can tell the first laparoscopic assisted vaginal hysterectomy was done by the great Kurt Sem, and you can see his picture with his model and simulator. And the first reported total laparoscopic hysterectomy was in 1988 by Henry Reich from the US. He took 180 minutes. I think you can still see his videos in the AAGL library. Patient discharged on day 4. And the first report of robotic hysterectomy was in 2002. Later on, we learned about single port surgery, mini laparoscopy, and recently vNOTES. However, there's much geographical variation in the availability of these techniques. So indications, I'm going to quickly go through them: cancer, endometriosis, adenomyosis or pain, heavy bleeding, prolapse. Obstetric is an interesting one, which is for life-saving measures. Prophylactic for after genetic advice. And sometimes I've seen in certain countries hysterectomies for contraception, which is like not the norm in other countries, but this is if somebody has a mental retardation in Thailand, for example. I remember 2 cases on the list were for contraception, which I questioned, but this is like, rare. The surgical approach, I mean, this is from this paper, but you have more approaches. The vaginal one, which is the least traumatic, scarless, and still recommendation #1 by ACOG. The abdominal one, it gives you the maximum exposure, access, especially in big masses and in oncology. Laparoscopic, it takes longer, but needs training, and also needs devices, is more expensive, but it is best for the patient. Robotic, there's even more precision, there's no tremor, and you have 3D view, and there's less blood loss, but needs a lot of equipment and training. So the policy of hysterectomy and technique is variable among centers, countries, sometimes in the same country, sometimes in the same region. even between a trust between two hospitals in the same trust. The factors that affecting decision-making is availability of surgical skills, parity, mobility, pathology and the uterine size. Quickly going through the morbidity mortality, overall morbidity is 6.1. Short-term mortality is 0.3 per thousand for benign cases. The higher risk for morbidity is younger age, fibroid, malignancy, peripartum, and if there's any other surgical morbidity. So the commonest morbidity is blood transfusion, which is 2.6%. It looks worse in abdominal hysterectomy. Bladder injury in abdominal hysterectomy is higher, although with the vNOTES, it is one of those things that is mentioned. The Hanlon study, bladder injury probably a bit higher. We'll come to it in the presentation with Jan. Ureteral injury, abdominal hysterectomy 0.2, vaginal hysterectomy 0.1%, and it is less than 1% in total laparoscopic hysterectomy. Bowel injury, abdominal and vaginal hysterectomy 0.1%, and less than 1% in TLH. Bowel dehiscence, so far the evidence showed that if you suture vaginally is the best. It's worse with laparoscopic suturing, and there is a lot of debate about that. So just going through the risks: anesthetic risk, positioning, urological, bowel, hemorrhage, infection, thrombosis, wound complication, bowel dehiscence, and death. The sequelae is unintended menopause. Sometimes people have regret from hysterectomy, which is underreported. Apical weakness, 1 in 3 will have vault prolapse. Loss of fertility is a concern if you operate on a young lady for cancer. We forget to mention about vaginal shortening, radical hysterectomy, which can be a problem later on. You may see the patient in the clinics and affect sexual function. Bowel dysfunction due to adhesion, disruption of pelvic nerves. I did an audit. 100% of my patients in the first 6 months when I started my job in hysterectomies, they have constipation, so I routinely give them something to move the bowel. And bladder dysfunction, sometimes you get de novo bladder symptoms after a hysterectomy. So we need to think again about alternative strategies for the consent purposes: ablation, endometrial resection, marina, hormonal therapy, interventional radiology. However, we all know that hysterectomy also, although it's less safe, but it can be the most cost-efficient approach to solve a problem. Now, we also want to touch on hysterectomy and sex. This is under-researched, but usually if there's pain and cancer, generally speaking, sexual function improves. Sometimes people report loss of drive and pain, loss of sensation, plus the effect of menopause, but we need to know that female orgasm is mostly related to the collateral and anterior vaginal wall, but more research needed here. So I just come to the, again, ACOG and RCOG recommendation. Mainly ACOG is saying vaginal hysterectomy is the first choice, if feasible. Recommendation for TLH is from BLAP2 study and in endometrial cancer. What affects the patient is the wound. In high BMI and comorbidity, the wound is what makes people unwell after that. Hysterectomy should be in the context of a program of enhanced recovery, and this is adopted in many specialties. So here we come to which way you have to do the hysterectomy. You have, as a patient or as a service provider or as a college trainer or as a health commissioner, you have options of vaginal, abdominal, multi-port laparoscopy, mini laparoscopy, single port, robotic, or vNOTES. I always, this is my quotation, I believe surgery is a calculated injury to the anatomy, physiology, and psychology to achieve a defined target. So how can we make the surgery the least traumatic, almost, as the least injurious to the patient? In preparing of this, I borrowed some slides from Ms. Caroline Bell. She is CNS nurse hysteroscopist and colposcopist from the BSG committee member. And also I thank Gynae Fellow team, amazing, wonderful people, Mr. Azam, and the technical and educational support I got. And I thank you for participating, Dr. Thomason, and also thank Jan. I am grateful for Jan who showed me the way. I attended his theater, and I will